Fighting Blindness Canada's Viewpoint is a virtual education series that brings you the latest in vision research presented by health experts from across Canada. The webinar you're about to watch is a recording. To learn more about the research we fund and upcoming webinars and events, please visit our website at fightingblindness.ca. This Viewpoint webinar is proudly presented by Bayer and supported by Novartis, Allergan, Janssen, Biogen, AGTC, MeiraGTx, and the SickKids Foundation. We'd also like to thank Accessible Media Inc., our national accessibility partner. Everyone should download the AMI app, which is a fabulous resource, and you can watch excellent programming, including previous Fighting Blindness Canada events. Thank you for watching. We hope you enjoyed this webinar and share your thoughts with us in the comment section below.
Thank you very much for the very nice introduction. I'm going to share the screen. Here. Okay. Did you see the first slide?
Yep, looks good.
Looks good. All right. Well, thanks again for Fighting Blindness Canada that sponsored this research, and thanks for having me to give this talk. So once again, my name is Alan. I'm a resident from University of Montreal. So today our talk will be about retinopathy of prematurity. So we'll talk about what we know about this disease and what needs to be done in the future. So when I started research on ROP, I just did what you do normally, that is going to Google. And on the Google Journal of Medicine called Wikipedia, I saw this entry, which is about Stevie Wonder. And he is the international spokesperson for ROP. So it reads, Stevie Wonder was born in Michigan on May 13th, 1950. He was born 6 months premature, which along with the oxygen-rich atmosphere in the hospital incubator resulted in retinopathy of prematurity, a condition in which the growth of the eye is aborted and caused the retina to detach, so he became blind. Hopefully after this presentation, you can appreciate which part of the statement is right and which part is not quite right. So this is our game plan today. So I will start with a brief introduction to ROP, talk about how it happens and how we are managing it. Then we will dive into what we know about it and what we can do even better. Then there will be a Q&A section at the end. So ROP was first described in 1942. At that time, ophthalmologists observed fibrous-like tissues behind the lens. So now we know that this fibrotic tissue was in fact the detached retina, which represent the worst consequence of ROP. So soon after they observed that retrolental fibroplasia, they make an association between this condition and the excessive oxygen supplementation that was needed to save these premature infants' lives. So now we know there are three greatest risk factors for ROP. First is the low birth weight, especially those who are born less than 750 grams, low gestational age, born less than 26 weeks, and excessive oxygen supplementation. So back in the 1950s, the oxygen chamber or supplementation wasn't as well designed as we have today. So the concentration was either too high or too fluctuating. And that is an important factor that triggered ROP. And knowing the importance of oxygen target, back in the 80s, there were a few studies trying to use a lower saturation target between 85 and 90%. However, that was associated with a 45% increased risk of infant mortality. So now in most Canadian centers, we use 91 to 95% oxygen, which can effectively reduce ROP by about 30% compared to giving them 100% oxygen. So in 1980s, thanks to multiple innovations in neonatal care, such as surfactant, which is a medication used to treat respiratory issues, there have been steady increase in infant neonatal survival among those premature babies. And so did the incidence ROP. As you can appreciate in this figure, in 1990, there was only about 2% of infants diagnosed with ROP, but in 2010, the percentage jumped up to 15%. And this graph shows the global distribution of ROP. As you can see here, the biggest population happened in Asia, followed by high-income countries such as Europe and North America, quite a bit of ROP patients in Latin America, as well as the Caribbean. Based on the latest statistic in 2013, we had about 185,000 cases of ROP in the world. 20,000 of them became blind or severely impaired by the disease. Another 12,000 suffer from mild to moderate visual impairment. In order to understand how ROP takes place, let's first take a look at the development of the normal fetal retina. So the retina, in fact, developed quite late. So it's not until the 16 weeks of gestational age, that's about 4 months after the infant was conceived, that there are few retinal vessels started to sneak inside the retina alongside with the optic nerve. In the following weeks, these vessels will grow peripherally, and by 32 weeks, about 70% of the retina is covered by the retinal vessels, leaving a little avascular zone at the periphery. And then it's not until the end of the gestation, almost like when the baby is born, that the retina is fully vascularized or covered by the retinal vessels. So you can imagine if a baby was born very young at 23, 25 weeks, that their eyes have a large avascular zone. The younger they are, the bigger the zone it is. Here is a cross-section of the retina at the back of our eyes. And an interesting fact to appreciate is that the retina is a very, very active tissue. So that's why it has two important blood supplies. The anterior blood supply here is called the retinal vasculature, which we just saw, the ones that sneak into the retina and gradually covering the whole eye. So this vasculature provides about 30% of the oxygen and nutrient to the entire retina. Underneath of the vessels are multiple layers of neurons. And the outermost part of the neuron are the photoreceptors, the rods and cones. They are the light detecting cells in our eyes. Underneath the photoreceptor is a single layer of cells called the retinal pigment epithelium, or the RPE cells. You can consider them as the housekeepers for the photoreceptors because they play a very important homeostatic role. For example, they transport the oxygen from the underlying vessel to the photoreceptors, and they also clean up the debris produced by the photoreceptor. And underneath the RPE layer is our second blood supply to the retina called the choroid. And in fact, it's the major blood supply that provides about 70% of the blood. So how does ROP happen? Well, actually, there are two steps that needs to happen for ROP. So the first step, the combination of prematurity and oxygen therapy cause the degeneration of the retinal vessels. So we call this phase the vessel obliteration phase. The vessels are dying. And that causes a local lack of oxygen in the retina here. And our body has this amazing mechanism to counteract this problem. That is by producing a large number of growth factors called the vascular endothelial growth factor. In a very short amount of time, the retina produces a large amount of VEGF, and that pushed the process into phase 2, the chaotic, disorganized growth of retinal vessels. So we call it neovascularization. So this process is more of a conventional or traditional model of ROP pathogenesis. And back in 2011, in the lab where I did my PhD, they found a second important component of ROP, that is thinning of the choroid, the major blood supply. So if you think of ROP, it is the problem of two vasculature. It is the uncontrolled growth of the retinal vessels and thinning of the choroid. An important step in managing ROP lies in ROP screening. And in fact, the protocol is very stringent. The goal is to offer a diagnosis so that we can treat the condition early. So most severe ROP usually develop between 32 to 36 weeks. So when the babies are born prematurely, we usually wait a couple weeks to perform the first screening. And we offer this screening to those babies who are born less than 1,500 grams or younger than 30 weeks of gestational age. Once this baby regain their physique and discharged from the hospital, the duration and frequency of their ophthalmology follow-up largely depends on the severity of their disease. And so far, no long-term follow-ups are mandated by the guideline. And technically, most patients are discharged after the first year. So how is ROP treated? We have gone through a long way in terms of treatment. So back in the 1980s, we had cryotherapy and scleral buckling. So for cryotherapy, we use a freezing temperature to ablate or remove and stop those abnormal vessels. And if the infants unfortunately develop retinal detachment, we can use scleral buckle, a surgery to treat that. In the 1990s and early 2000s, these two techniques were gradually replaced by laser. So instead of using a freezing temperature, we use a very well-controlled, precise laser to burn off those abnormal vessels. And instead putting a scleral buckle, now we have the modern vitrectomy to remove blood inside the eyes and to reattach the retina. And since the 2005, there's a huge push in using anti-VEGF injection to block the action of those growth factors and eliminate neovascularization. And this is a very hot research topic these days. So we've known a lot about ROP, but how about the long-term consequences of this disease? One thing for sure is that many ex-ROPers have high myopia and astigmatism during childhood, but ROP is really a retinal problem. So what's the long-term impact on the retina? And the second reason we asked this question was there is a component of choroidal thinning, which represents 70% of the total blood supply. So if the blood supply is impaired, shouldn't that precipitate retinal problems? So that was the first question in my PhD thesis. And we used a rat model to study that because I can follow the rat from day one they're born until the end of their lifespan. And this is a graph from my colleagues' research back in 2011. They reported an immediate choroidal thinning on P7 rats, so 7 days after they are born. As you can see here, the ROP rats had a much thinner choroid starting on P7 and lasted until P14, and that was the last day of their experiment. So my question at that point was, how did the choroid respond to that thinning? Does it undergo neovascularization just like the retinal vessels? Does it undergo normal revascularization just catching up? We don't know. So I did a much longer experiment and followed the rats for 200, 300 days, so at the end of their lifespan. And the results was very interesting because we observed a persistent thinning of the choroid throughout the life of these animals. And soon after we published those papers, a field clinical study also confirmed our observation. So take this study as an example. They observed choroidal thinning in teenagers. And in fact, this group of patients had very mild ROP because they are spontaneously regressed. And there are several other research who look at children with different stage of ROP and undergo different treatments. And they also came at the same conclusion, that's choroidal thinning in those who had ROP as an infant. So how about the photoreceptors? So these are the pictured cross-section segment of the retina, similar to the cartoon I just showed you. If you pay attention to the total thickness of the retina, you can appreciate the ROP rats have much, much thinner retina compared to the normal. And if you look at the photoreceptor layer here and here, the ROP rats also have fewer photoreceptors. And that was translated to a much weaker photoreceptor response as measured by electroretinogram. So similar to the EKG we had at hospital, we also have a machine that can detect the retinal activity. So how about older rats? So in older ROP rats, their retina becomes even thinner. It's about one third of the normal thickness, and so is the photoreceptor layer here. And in terms of their photoreceptor function, retina function, it's almost a flat line by the time they age. So what do we learn from the animal models? We know that choroidal thinning is persistent throughout life. We saw a diminish in photoreceptor population, a decrease in their response. Although I didn't have the chance to show you, we also observe an increased number of abnormal RPE cells. That means the housekeepers are not working well to keep the well-being of the photoreceptors. So during my residency and for this project, our goal is, we are just wondering, can we observe the same phenotype or same pattern in our ROP patients in the clinic? So let's see into the future and study the long-term impact of ROP. So in this project, among our pediatric population, teenagers, we hope to monitor the retina anatomy and functions. As for the younger and mid-age adults, besides monitoring their retinal status, we also ask the question, do they develop any retinal conditions at a much younger age? That is ROP a risk factor that underlying these diseases? And for our older population, we wonder, do they have a more aggressive course of any retinal courses if they have ROP as a baby? Or does ROP have an impact on the prognosis or progression of their pre-existing eye disease? Again, our goal is to have early detection of any eye problems in this population throughout their life so that we can offer a very timely management to maximize their visual potential. So in our journey to battle ROP, and I think that's a very beautiful story, how we, back in the 40s, we encountered a new disease. We didn't quite understand it. And then we came to understand it, have more insight on this disease. And we have a good and stringent screening protocol. We offer treatments. And in the last 2 decades, we upgrade our treatments from one to another. And now we have even newer methods. So now I think in 2020, it's the time that we look into the future and study the ripple effect of ROP. So now let's go back to the first slide about Stevie Wonder. So what's wrong with this? Like, what's right about this statement and what's wrong with it? So it said Stevie Wonder was born in Michigan. He was born 6 weeks premature, which alongside with the oxygen-rich atmosphere in the hospital incubator resulting in ROP. So that's right, because both prematurity and oxygen-rich environment are risk factors for developing the disease. And that's why we carefully monitor the O2, the oxygen saturation in hospital these days. And then it says ROP is a condition in which the growth of the eye is aborted and causes retina to detach. Not quite, because it's not the whole eyeball that is aborted. It's only the vascularization of the retina that's partial or incomplete. So if we can address this part, that we can actually treat ROP effectively. And also it's not because the lack of vessels that cause the retina to detach, it's in fact the neovascularization that pulls the retina off. So, and that's why we try to laser those vessels or give anti-VEGF. If we can treat those traction coming from the neovascularization, we can prevent retinal detachment. And unfortunately, Stevie Wonder was blinded by ROP. But in the last couple of decades, we have very effective ROP screening with early treatment. So these days, the incidence or the chance of blinded by ROP has reduced significantly. So with that, I thank you for your time. Merci beaucoup, and I'm open for questions. Back to you, Morgan.
Excellent, thank you. Thank you so much. Okay. So, so we have time for questions now, which is great. So as I mentioned in the beginning, there's a couple ways that you can ask your questions. So there is at the bottom of the screen a Q&A box. You can click and type your question into there. You can also email me at mineson@fightingblindness.ca, and I will monitor that. And the other way you can do it is by raising your hand. So you can raise or lower your hand by using some keyboard shortcuts. So if you're using a PC, you press Alt-Y, and on a Mac, you can press Option-Y. And so when it's your turn, I will call on you, and you can unmute your microphone. Okay, so I have some questions here that came in. So the first one is, how do you screen babies for eye disease?
Yeah, so let me go back to that slide here. So for screening eye disease, like we follow this schedule, and actually most of the time those very premature neonates, they still stay in the NICU. So the ophthalmologist will bring their indirect ophthalmoscope and then with their lenses to go in the NICU and follow them and screen them. So it happens in the NICU. Great. Does that answer the question?
Yeah, so is there any evidence suggesting why some babies have more severe vision loss while others have more mild symptoms?
Yeah, sure. So it's basically, baby who are born much younger, let's say 23, 24, their disease are much more severe because it's just the avascular zone is bigger. And also they found there's a difference in race. The African descent tend to fare a little bit better in ROP than the rest, So that's one factor as well. And also screening is extremely important because there's an ET-ROP trial that show that if we can catch those problems early and offer very early treatment, and that goes a long way for these patients. What else? Different modalities of treatment makes a difference. Now we can choose anti-VEGF, laser, and vitrectomy. So I think in terms of treatment and then treatment outcome, we actually, improve significantly in the last 2 decades.
That's great news. Moana asks, does choroidal thinning happen throughout the retina, or is it only sectoral?
Yeah, very good question. So from the animal experiments, and so we look at the whole choroid and retina. So mostly it happens, unfortunately, in the most center of it. So the part that covers the optic nerve and covers the macula. And even in the clinical study, most study specifically look at the subfoveal choroidal thickness. So which is because in the fovea, it's not covered by the retinal vessels. So all the cells receive blood supply from the choroid. If you have a thinning of the choroid, that's their only blood supply. So it's a big problem. So yes, most of the choroidal thinning happens centrally.
Great, and Romolo asks, what is the best visual acuity that can be obtained after treatment?
So the best visual acuity, can be 20/20. If the baby doesn't have very, posterior disease that, threatening the macula, threatening important part of the retina or the macula, that's what I meant, that, they may have a tunnel vision, some of the patients, but they can actually achieve quite good outcome.
Great. Linda asks, what is regressed ROP?
Oh, spontaneously regress ROP. What it meant is that, so basically, a lot of ROP patients, their disease are so mild that you just watch and wait until, you observe the neovascularization or just chaotic growth of the vessels, then you treat those things. But if, the presentation is so mild, you just wait on it, sometimes it will disappear. The infant just outgrows the disease. I think that's, the beauty of pediatric is that those babies are so strong. Sometimes they can beat the disease on their own. Sometimes we give them a little bit of help and they get better. Yeah.
Great. So I have another question here and a couple in the email that are asking, I guess, about maybe the genetics of the situation. So Isabel asks, I had a retinal detachment at 20 years old. Does my child have a greater risk for ROP? And some other people are asking kind of in the same vein, is ROP inheritable? Are there specific genes that are involved?
Yeah. Great questions. So ROP is not a genetic eye disease. It's not inheritable. However, prematurity has some genetic components or like familial history component of it. But ROP is really caused by prematurity. So a baby born too early, and the oxygen supplementation we offer. In fact, ROP is an eye disease of those infants who make it through prematurity, right? So if that's why oxygen monitoring plays an important role. And I don't think our ROP will, pass down in the generations, that's for sure. But there are definitely some genetic components maybe for prematurity and stuff. So yeah.
Yeah, that's great. So another question that we had here is, are there other comorbidities that go along with ROP? So for example, if someone has severe ROP, are they more likely to have other issues like heart disease, hearing issues, etc.?
Yeah. So in fact, there are quite a few long-term sequelae or comorbidity associated with prematurity, so like being born too early. So they know that obesity, diabetes, even heart attack is associated with prematurity. So what happened when these patients were born too early, right at the beginning of their life, have a very long-term ripple effect that extended into their adult life, even when they are elderlies. And so that's why, and exactly the idea that triggered this project is like, we wonder, ROP is such an early, it's a disease that of right at the beginning. And let's say AMD and diabetic retinopathy didn't happen until they're like 60s. So, is there a connection between these two eye diseases as well? So I guess to answer your question is yes, prematurity represent a risk for quite a few conditions. And in terms of ROP, it's well known, like I mentioned, that myopia, astigmatisms are quite commonly associated with this condition. Yeah.
Yeah, and I guess in a similar sort of vein, are there any preventative things that people can do to reduce the risk of ROP, either before birth or if someone is born prematurely?
Yeah, great question. So there are quite a few, research or clinical trial trying to give supplementation growth factors to the kids, because let's go to the pathogenesis here. So in the phase 1, let's say in the phase 1 vessel proliferation is actually caused by prematurity. The reason for that is that the baby is, comes out too early, and then he or she doesn't receive enough good stuff from mom, So by giving some growth factors like IGF-1, things like that, now hopefully we can prevent vessel obliteration or prevent the degeneration of these vessels. So if we can prevent phase 1, there won't be a phase 2. So that's the idea. So far, these clinical trials are still at the research phase. So I think that's another thing that we can look forward to. Yeah.
So are there any preventative measures that someone could take during their pregnancy, for instance?
To prevent ROP, you mean?
Yes.
Actually, maybe to prevent prematurity. I mean, the risk factor for prematurity sometimes is infection, inflammation. Those are risk. So instead of preventing ROP, I think it's more important to prevent preterm labor. So that's also an interesting area of research. But once the baby is born prematurely, that we actually need to work, avidly with the neonatologist, with ophthalmologist to prevent ROP. Yeah.
And can ROP lead to visual deficits that are not immediately detected?
Absolutely, and that's, actually that's the heart of our research, because as I mentioned, most ROP patients are discharged from the hospital, follow up after 1 or 2 years. And the criteria for discharge is that you look at the fundus, the bottom of the eye of this patient, and you say, okay, great, the retina looks great, there's no detachment, the vessel looks great, and then you discharge them, right? But then you don't know if the connection between the neurons are great, maybe not, because there's a component of choroidal injury, there's a component of retinal injury as well. And in fact, in the animal model, we know that their retina is not great. Like, they look normal, but then the connection between the neurons are not great. And also there was some early study from Boston Children's Hospital also showed that adolescents and children who had ROP, they have photoreceptor issues. Their rods and cones are not as robust as their age-matched healthy controls. And so that's why in our future study, we hope to monitor children's photoreceptor status a little bit closely, and just to detect the the function of the neuron much better than just relying on the fundus exam.
And you mentioned that the treatments have sort of evolved over time, and now sort of the treatment that is used most often is anti-VEGF injections. So, I mean, we've talked at other sessions about how these drugs are used for people with age-related macular degeneration or diabetic retinopathy, and they're usually delivered over like a sequence of weeks. Is it the same for the babies? Like, is it like a one-time injection? Are they getting multiple injections? How long does that last?
Yeah, so all those are actually open questions, because what I know so far is that in terms of dosage, the baby is so much smaller than an AMD patient, right? But then they use half the dose. And then in terms of the indication, it's very specific. There's a specific zone, like where the ROP is and how severe it is. So, and also in terms of research, I think we're still right at the beginning. And there, in terms of the frequency, duration, how often we give, there's, a lot of people just go, it's a kind of house rules, but then I think we still need, still some miles to go before we have a more some rules that are set in stone.
For sure. And are you using different types of these drugs? Like, so I know, we've talked recently a lot about like Broview, this new anti-VEGF drug that's coming out that has like a longer span of life, a smaller molecule. Is there any benefit to that? I mean, from the very basic level, I'm thinking like smaller molecules, these tiny little eyes, does that make a difference? Or is it just all about the dose?
Yeah, great question. I mean, definitely they need to compare of all those molecules. One important thing to consider, maybe I can pull out that slide. Here is the pros and cons between, laser versus anti-VEGF. They are both great options, right? One thing is that there's some research showing systematic leakage of anti-VEGF injections. That means you inject in the eyes, and then they take the blood from their arms, and they found, the medication leak inside into the vessels. So, and that lasted for about 2 weeks. And that kind of associated with a lower VEGF level in these babies. And, VEGF is an important growth factors for the brain and basically for anywhere in our body. So will that pose a long-term problem? We don't know, because this medication is so new, like in terms of using in ROP is relatively new. So I think, in terms of anti-VEGF, you have bigger molecules, smaller molecules. And I think, once again, it's an open question.
It's really interesting. Romolo is asking, is there any correlation between ROP and developing retinitis pigmentosa? And can research on ROP help or influence the other?
Yeah, good question. So there's no correlation between ROP and retinitis pigmentosa, because they are different. The the mechanism is different. ROP, in a sense, is iatrogenic, like caused by physicians, caused by the life-saving oxygen. But then also, by modifying it, we can improve the outcome. And in terms of retinitis pigmentosa, it's genetic condition, it's mutation of of certain genes, so they are different. And how can study in ROP help others? Is that since the 1980s, we have a large increase of preterm infants who survived, right? You remember that growth, that chart is like shooting up. So I think in the next couple of decades, this population will just get older. I think this population right now are in their 40s and 30s. And when they reach their 60s, will they have AMD at a much younger age? Will they have diabetic retinopathy at a much younger age? And, and will their retinal disease just become so hard to manage due to ROP or like associated with ROP? And all those questions are pretty interesting to know. And I think that's exactly why we are doing this research.
Absolutely. I guess sort of, just coming off that question, the next question from Matt is, if someone has ROP but is now older, so an adult, are there any treatments that can help improve their vision now?
Yeah, that's actually the question, kind of like the question after this research is that what can we do to help them better? So what I think right now is that if you already have ROP, you have ROP in 1980 and 1985, and then you have some sequelae, maybe there's not much we can do at this point. And I hope that if we can offer you, participate in our research, if we can find some problem in the retina, we can catch it early on and offer early treatment. Let's say if you have a retinal vein occlusion, whatever, that we can offer an early treatment, that will be great. And otherwise, what we hope is that if we can design a protocol for long-term follow-up for all our ROP patients throughout their childhood and adolescence, or maybe a few times during their adulthood, to monitor these subtle retinal changes and offer early treatments. And I think that's what we hope to offer to all our ROP patients.
Absolutely. So someone else has asked, besides the elevated oxygen levels, which you've talked about, are there other medical interventions that are used for preterm babies that could contribute to ROP or other visual problems?
Are there medical interventions used for preterm babies? Let's see. So for example, ROP mainly is the oxygen, and also it's the fluctuation of oxygen that caused the problem. So no other factor that I know of that could contribute to other visual problems. Well, in terms of other visual problems, so we know that prematurity is also associated with myopia, a lot of, and then the corneal asymmetry or irregularity. So not specifically caused by medical intervention, but prematurity per se, it's a huge risk factor for basically anything. Yeah.
Okay, so I think that's all the questions. I'm going to do one last check of my email, see if any more came in. I think that is it though. So thank you so much. Ellen, did you have anything else you wanted to mention before we go?
I'll just say that thank you for the opportunity to present here. And then I think those questions are great. Keep it coming.
Yes.